Good afternoon, everybody, and thank you for joining us. Today is March 13th, 2020. It is 2 p.m. Pacific time, and this is the Los Angeles County Emergency Preparedness Updates provided to you by the California Association of Health Facilities Disaster Preparedness Program. Many of you know that we have an ongoing grant with Los Angeles County to provide updates for DRCs, or the DRC updates for skilled nursing facilities. But we've modified our original, our normal criteria and our learning objectives to support the COVID-19 response in our facilities. So we've gathered some of the best and brightest from Los Angeles County to come help us talk about the information, transmission guidance for transfers. We'll talk about testing. We're going to talk about a bunch of stuff, but we've got a ton of material, and I'm going to try to breeze through these first few slides really quickly. Joining us today is Dr. Zachary Rubin and Dr. Prabhu Gounder, both from Los Angeles County Department of Public Health, and Lori Lee Brown, who's the contract manager for the Disaster Preparedness Program, LA County EMS. She's also our contract manager for our grant as well. We'll talk about a bunch of acronyms as we go. As we get to the acronyms, we will attempt to spell them out so we don't confuse folks. All right, and we know that there's approximately 400 SNFs in Los Angeles County, and those folks are spread out in the following geographic area. This is a good snapshot to see where you and your neighbors are located next to each other. And this is usually in response because we tie you to a disaster resource center. We've had to change how those disaster resource centers work, and certainly they've been immensely impacted. We're not going to talk about the disaster resource centers in this webinar, but if you have questions about DRCs and things like that, please email them to myself or to Courtney afterwards, and we can explain how the DRCs work. All right, so today, transfer guidance, emergency staffing resources, return to work criteria, wide-scale testing are the things we're going to cover today. So rather than me try to interpret this stuff, and you have a non-clinical person trying to relay highly complex clinical information, I felt it best if we could have the folks that oversee the application of these rules and the development of them on the call. So with me is Dr. Rubin, and we asked Dr. Rubin to join us today to talk about the transfer rules for patients in Los Angeles County. Now, I want to make this clear. If there are folks from outside of the Los Angeles County area, this is specific to Los Angeles County only. And while other counties may have a similar interfacility transfer rules, they may not be the same. And I highly recommend that you confer with your local health department to make sure that this is the process that you're to use in that county. So with that, Dr. Rubin, can you walk us through these interfacility transfer rules, and let me know when you want me to change the slide, and I can go ahead.
Okay. Thank you, Jason. Yes, so the interfacility transfer rules, I think, have been a significant source of discussion since we first kind of implemented these back in the very beginning, and they have evolved over time. So if people have, been used to, had a printout of the original transfer rules back from, 6 weeks ago or 2 months ago, they've significantly changed since then. And I think we've tried to make them as simple as possible, but unfortunately, they just kind of get complicated over time as we've dealt with more and more kind of situations that initially we didn't really think of, and then we had to later put into new iterations of the interfacility transfer rules. So these are still evolving rules, but so far they haven't changed for the last few weeks. So I'm happy to go through them and try to kind of explain what we're trying to get at with these transfer rules. The main idea behind the transfer rules is to try to decrease the risk of setting off an outbreak in a skilled nursing facility due to a premature transfer of a patient who may still be in an infectious period with COVID-19, from a hospital to a skilled nursing facility. So as you may be aware, our rules have actually been significantly different than the rules put up by the CDC and the state of California. And actually there are a couple of reasons for that. We've actually put a 10 or 14 day limit on transfers and from acute care hospitals to most skilled nursing facilities. And the reason for that was based on some studies that came out of China fairly early on that showed that people who are hospitalized with COVID and are sicker than the average patient with COVID can actually continue to shed live virus for up to 12 days afterwards. So that's where that 10 to 14 days comes out. And initially that was significantly different than the CDC recommendation, which was 7 days. But now the CDC has actually pushed that out further to more than 10 days because they did have problems with transferring infectious patients to skilled nursing facilities and then having an outbreak in the receiving facility. I can say, I'm knock on wood, that we really haven't seen that as a major cause of outbreaks in LA County because most of the outbreaks have actually been caused probably by staff coming into the facility infectious and transmitting. But anyway, so I'm going to go ahead and just kind of jump in here. So these are this specific slide talks about patient returns from an acute care hospital to a long-term care facility. The first thing, patients may be transferred when clinically indicated. This is really for facilities, skilled nursing facilities that are receiving COVID-positive patients and that are designated COVID facilities. So this is not true of most skilled nursing facilities that have not had outbreaks. So I'm going to go through and kind of clarify that a little bit because I think that first line may be a little bit difficult to interpret. But basically, whenever a patient is transferred, I would just go back. So transition-based precautions should be continued for 14 days after hospital admission. So even if a patient is transferred earlier than 14 days, for example, 10 days, we're still requiring that the facility keep the patient in transmission-based precautions, so contact, droplet with eye protection for 14 days. So we're considering them infectious for up to 14 days after their first hospital day. So it's a little bit different, and it's slightly different than you'll get if a patient is not hospitalized. If the patient is not hospitalized, we would time the 14 days from the date of symptom onset or the first day of a positive test for patients who are asymptomatic. But for patients returning from acute care hospitals, we start day zero. Day zero or day one is the first hospital day. And so we would count the number of days from the hospital admission day. Again, this is because patients who are sick in the hospital tend to shed the virus longer. And then the bottom point here, facilities experiencing outbreaks are closed to new admissions by the Department of Public Health. They are not closed to returning cases. So if the patient developed an infection, a COVID infection in the skilled nursing facility, we are assuming that your skilled nursing facility has additional cases and should be isolating, should be set up to isolate the patients. That may not be true if you're having problems with staffing in the middle of an outbreak, and we did see that pretty frequently. So if the problem is that you can't take a patient back because you don't have the staff to take care of that patient, then that should be communicated out to the Department of Public Health. Otherwise, we are expecting all facilities to accept their patients back, their patients who develop disease in your facility and were transferred to acute care hospitals. We are expecting you to accept that patient back when clinically indicated. If that patient is clinically stable, in discussions with the acute care hospital, that patient can come back even before the 14 days, but would need to be then in transition-based precautions until they reach that hospital day 14. Next, Jason, please. Back one. Okay. And this is kind of what I'm getting at as well. This is new admissions to long-term care facilities. So if a patient is at acute care hospital, it's not the returning patient, but a new patient from acute care hospital, they can be transferred after 10 days to the long-term care facility, but they need to stay in transition-based precautions until 14 days. If that patient, however, is already past that 14-day period, you can admit that patient as long as they are clinically stable and have clinically improved. You can accept that patient back prior to after 14 days. And you can either require testing or not. So the two, well, actually, I'm sorry. You can either use a test-based strategy, which I would kind of argue against in a lot of these patients, or you can actually wait till 14 days have passed and then accept the patient back just based on the time period. The reason I say the testing is a little problematic is because we've found that a lot of patients will actually have prolonged shedding of RNA from the virus and can be detected by PCR. The longest one I've seen so far is 48 days. So those patients, are clinically improved and probably do not have viable virus, but you can still identify the DNA or the RNA in the patient when you do PCR testing. That's just residual viral RNA that's probably not clinically meaningful. And that is problematic because some of these patients will have, like I said, a prolonged time of shedding, which is not that clinically important. So I would kind of push towards a time-based strategy where you would accept the patient back after 14 days, and then at that point you do not have to, you're not required to put the patient in transmission-based precautions. You can actually take the patient back and put them in kind of the general population in your facility. And that's it. So Jason.
Oops, I'm sorry. Yeah, I think I skipped oh no, I didn't skip a slide. Okay. So Lori added a few slides into the presentation on the alternate care side, but I think I will go back to those once we finish with the interfacility transfer rules. How's that?
Okay. And then, so those interfacility rules that I talked about before are for patients with coronavirus. And we do have interfacility transfer rules for patients without COVID-19. And, I'm not going to go through them in immense detail because they're a little complicated, but I would recommend that you kind of look at this pretty closely and kind of follow this. So basically what we've tried to do is differentiate patients into different risk categories. So there's kind of a low clinical concern and then or no clinical concern and then kind of a higher clinical concern. So the low clinical concern are for really patients that are transferred, or start out with no clinical concern. So those are for patients that really are transferred to acute care hospitals for things that are not at all infectious. So someone, falls and breaks a wrist or an ankle or a hip. Those patients, can be accepted back as long as they've had no symptoms of infection. And you do not need to wait for those 10 or 14-day cutoffs. Those patients should be accepted back as long as they've had no evidence of any symptomatology that could be consistent with coronavirus. If patients, however, have infectious symptoms that could potentially be related to coronavirus, then we would require some other level of proof that they don't have coronavirus in order to transfer the patient back to the long-term care facility. So, for example, if somebody has low pretest probability of COVID-19, meaning they had, for example, other symptoms like a fever, but some other underlying sources identified, such as a urinary tract infection, then those patients can be accepted back with one negative SARS-CoV test. So if the hospital does one coronavirus test in those kind of patients, they can be accepted back in. So again, you have to kind of differentiate in your mind the no clinical concern or low clinical concern and compare that to the higher clinical concern, which is on the next slide, I believe.
Yeah.
So Jason.
Yeah, I've got it. Sorry, there we go. Okay.
So these are for kind of patients who or potential PUIs or person under investigation. So people who may have symptoms that are consistent with coronavirus, like fever, cough. There may be an exposure risk, such as someone was in contact with somebody with coronavirus. And in these cases, we really require the patient to be tested twice for coronavirus before they come back. And the reason for that is the test itself is not a perfect test. And so in a situation where you have kind of a higher pretest probability, meaning they have a higher risk of having coronavirus, you want to have two tests that kind of corroborate each other before you transfer the patient back to your facility. So again, it's very important to kind of differentiate between your low or no risk patients and the PUI or higher risk patients. And that's, without, I don't want to go through it in a lot of detail because I think it's written out there and confusing enough without me kind of bumbling through it. But, if you do have questions or concerns about these, you can always contact us and we can try to clarify the specific rules. But, what we have seen from a lot of facilities is that they are requiring 2 negative tests of all patients coming back to a long-term care facility. And that is not really our message from the Department of Public Health. So you need to look at these rules and be familiar with them. They're on our website. If you go to the healthcare provider tab on the LA County Department of Public Health website, and then you go to the healthcare facility website, then it's there. It's not. We don't have any PDFs anymore. We have kind of a little bit of a flow on the website, so you can actually kind of click through, and it'll give you, starting with whatever the situation is, it'll kind of give you some decision. It's like a bit of a decision tree, and can kind of walk you through some of the decisions on the website. But I definitely would recommend, when you are getting these patients transferred back, that you look at that and make sure you're aware of exactly what the rules are. Because if you refuse to take the patient back and the patient should be going back according to the transfer rules, then you may actually be in violation of a health officer order that was put out on April 24th, and licensing could potentially contact you and cite you for not accepting the patient back. So, it's important to look at these transfer rules, but even more if there's a problem with the transfer rules, if you are seeing a situation that's not covered under the transfer rules, or for example, you have some kind of a staffing problem or some other local problem that precludes you from reaccepting a patient back to your facility, even though that should be covered under the transfer rules, you can contact your Department of Public Health contact, and they will help guide you through this so you're not cited by licensing or anything like that. So I think that's all I want to say about the transfer guidance. Jason?
All right. Yeah, for sure. Thank you.
Let's see.
I think this has to do with after an outbreak. Yeah.
Yeah. So I think we, again, I don't want to go through it in too much detail, but I just would recommend people kind of review those and feel more comfortable. And this is just the one thing I'd say is, we do have interfacility transfer rules for patients going from one skilled nursing facility or one long-term care facility to another. The important part is you do not want to transfer a patient from an outbreak into a facility that does not have an outbreak. If you need to do that, you should contact us first, but we would recommend that patient be quarantined for 14 days after leaving the outbreak facility and before they go into kind of the general population in the receiving facility. So that's the important part is the goal for all these transfer rules is we don't want to start outbreaks in facilities that do not already have COVID. So if you have any concern about a patient being transferred to you and because you don't have any cases in your facility, look at these transfer rules, and with any questions, you can always reach out to us in the Department of Public Health for clarification.
Thank you, Dr. Rubin. That was fantastic. I think this would be a good point because you mentioned transfers in between long-term care facilities. Lori, if you're on the phone, what I'd like to do is go back and talk about transfers to Fairview alternate care site, we can talk about Fairview alternate care site and then other alternate care sites, if you've got a second. Are you there, Lori?
Yes, I'm here. Can you hear me?
Yep. Yeah.
Okay. I have not been able to connect to the webinar, so I'm just looking at the PowerPoint presentation. So I assume we're on slide 9, Fairview alternate care site.
Yes.
Okay, so I just wanted the audience to be aware that there is an alternate care site for COVID positive skilled nursing facilities who meet the admission criteria that I'm going to go over shortly. Again, the biggest thing is repatriating these patients back to their original facility, but it is intended to serve as a skilled nursing facility for COVID positive patients. And so if you have one of those situations that the physician was speaking about, it's an alternative. It's not in LA County, it's actually in Costa Mesa, which is Orange County. And it was the old grounds for developmentally disabled people. It's only eligible for people who are 18 or over, and it's an open bay design with no private rooms. So they have criteria that screening process, so it isn't like wide open skilled level 1 nursing, so the patient can't be at high risk for clinical indications that are critical. So, you know, if their O2 needs are escalated, if their vital signs aren't stable, if they can be discharged home, then they or, you know, to another their original facility, obviously they're not eligible. They have issues with this is basically the packets on our website, but people who are attempting to transfer patients to this facility don't complete the packet. So it's really important to go through the packet completely and make sure that the patient is hemodynamically stable, has no of the following conditions. So they can't have a C. difficile infection. They can't have a trach or a feeding tube. They can do gravity feedings, but not pumps. They like them to not be like severe dementia or have like psychiatric illness that causes acute agitation, which I imagine is a big portion of some of these patients. But they have the capabilities just like other facilities, so 24-hour nursing care. Some of the staff that was on the Mercy, the U.S. Navy ship Mercy, has, as that demobilized, has been transferred over. They can do insulin, diabetes care, bowel bladder training, limited work with the ostomies, and then superficial wound care. They're very limited on their PT, OT, and speech therapy, but they do have oxygen services, again, for low-level oxygen. And then they do not take, so the next slide would be the Fairview alternate care site. They don't take detox patients, severe mental health, complicated wound dressings, feeding pumps, and the big problem was discharge planning. So just want to make sure that there's a process to get that patient repatriated. I think the doctor talked about testing 2 times negative. The patients at this facility are tested twice a week, and after 2 confirmed negatives, they would be repatriated back to their sending facility. Another issue is just getting the MD to MD report. But we only have 12 patients that have been admitted into this facility. And from what I understand from a previous webinar, there's 2 other COVID-only facilities, Country Via South and then Hollywood Premier Healthcare Center. But we're not responsible for any of that. We're just an effort to, you know, ease the burden on the skilled nursing facilities. We worked with our partners to get this facility up and going, and arrangements are made through our medical alert center, and the packet is available on the website for transfer.
Perfect. Thank you, Lori. I put the, so on the screen now, you guys will see the flow chart of how you communicate if you need to transfer folks to the Fairview alternate care site. And you just follow that flow chart if this is a modality that you want to use. We realize these are set up to deal with large outbreaks, but they may not be able to take every resident you have. So you're going to have to work with your medical director to see if they fit the clinical criteria for admissions before you start this process. So review that before you start the process.
And Jason, I did want to say that I guess Public Health's website, I learned today, has more COVID positive skilled nursing facilities on their website. I don't have that information, but if the people want to go and look at other COVID positive skilled nursing facilities, you know, that was kind of the idea we had talked about early on before alternate care sites. your playbook that talked about how you get them up and running and how you work collaboratively with other skilled nursing facilities. So I think this is something that in the future we can work as a work group to get some sort of formal agreements in place for when flu season comes around in October and we're a little bit more prepared.
Perfect. Thank you, Lori. I'm gonna scroll back down to the section here. And while I'm doing that, I just want to let folks know that if they want a copy of these slides, there's a PDF version under the handout section, and there's also an evaluation if you need continuing education credits to download that and send back to us.
Actually,
all right.
Jason, can I
Yes.
add something quickly to
Yes.
what Lori was saying? So yeah, we have been, reaching, well, actually, skilled nursing facilities who already had outbreaks in their facilities and are now kind of coming out of it, and they have adequate staffing, PPE, and a lot of experience managing these kind of patients, are now have been reaching out to us to be designated as a COVID accepting facility. And so we have been working with, I think there's probably about 20 facilities now. Some of them are already posted on our website. Some of them are going to be posted hopefully in the next few days. But there are other facilities. We're not going to be the intermediary, so you can actually, people can contact those facilities directly. But the idea behind those is kind of the same as what Laura was describing. It's a kind of a safety valve for acute care hospitals and for skilled nursing facilities that may be having problems with staffing or may have, issues with, maybe they have one patient with COVID in their facility and they would like to transfer that patient out to a specific designated site to try to decrease the risk to other patients in their facility. So we have been designating these facilities. They've been coming to us and then we kind of vet them and then put them on our website. So there are some facilities out there. We're open to additional facilities reaching out to us, that have experience managing these patients and feel comfortable doing that. And so if other facilities feel that they want to go this route and try to be a service to the general community, acute care hospitals and other skilled nursing facilities, again, they can reach out to us and we're happy to kind of walk you through the process.
Thank you for that. And I'll just add on that, we've had the privilege of talking to a number of administrators and clinicians that have come out the other side after an outbreak. And I think lucky for us, they all feel, at least the folks that I've talked to, have all felt that the material support that they were offered by the public health folks at Los Angeles County was instrumental in helping them be able to meet this for the long term. And they've worked with them to develop a mitigation plan. And I know there's a ton of questions about the mitigation plan that's going to be required from CDPH. We've taken a lot of those lessons learned and combined them into a mitigation plan that we're going to cover in a 1-hour webinar on Friday. But frankly, it's too much information to cover here, but all of that stuff will be included in that mitigation plan. So I want to just jump to emergency staffing resources, because even though we hope we're trending downwards in terms of these large-scale outbreaks in facilities, especially now that we're practicing source control and really responding to the most current CDC guidance for infection control. We anticipate that we'll see a downward trend of these large-scale outbreaks. We may not see outbreaks stop, but we hope that the outbreaks that do happen will be less impactful, less folks have been exposed. But if you find yourself in need of emergency staffing resources, I think it might actually be a good idea to start planning for what your response is going to be now and how you're going to do that. CDPH has issued an AFL that kind of describes the decision-making process you should go through and how you should go about acquiring staff in an emergency situation. It really starts with the expectation that each facility is self-sufficient and that we have a staffing model that is adaptable to emergency situations, and we can do staff recall. We can onboard staff quickly, hire new staff. In emergencies, we could switch to 12-hour shifts. We got to look at MOU partners, especially if we have a COVID positive facility and we have MOU partners from other COVID positive facilities that could share staff to work the COVID positive areas. That's another real opportunity to partner with each other to do that. And then there's vendor resources, and I know I've talked to a number of folks about registry nurses and things like that. They're still it's not a perfect system, but to the extent you can, you will be expected to expire those vendor resources in the form of registry nurses before you would contact the Medical Alert Center or CDPH to ask for staffing help. Once you get to that point and you've already expired all those resources, then there's a process to request staffing directly from the MAC. We've released that information a number of times, but if you have questions about how to do that, please don't hesitate to contact us. And then as a last resort on that AFL, CDPH wants you, prior to any evacuation, let's say you've gone through this entire process and you still don't have enough staff to meet the needs. And you're on the verge of evacuating, you have to contact CDPH at the Medical Health Coordinating Center and let them know prior to the evacuation. They may have resources that they can send to you until LA County could provide those staffing resources. So that's the kind of the decision-making process you guys have to go through. It's described in that AFL, but if you have questions about it, please don't hesitate to reach out to us. So I don't know if Dr. Gounder or Dr. Rubin would like to talk about the return to work criteria. This is what I pulled off the Los Angeles Department of Public Health website. I think it's pretty standard. I don't know that it's much different than the rest of the state or CDC guidance, but maybe you could clarify that for us. Oh, I'm sorry, I pulled this off the CDC website, but I didn't see it on the LA website.
Yeah, this is Zach Rubin. So I can comment on this briefly. Yeah, so we basically just pulled we refer to the CDC guidance directly. So we haven't really changed anything from what the CDC recommends. So the only significant change that's happened over the last few weeks is that the CDC changed their infectious period from 7 days to 10 days. So that healthcare workers should be off for 10 days after their first symptom onset, or after their the first onset of, or after they've tested positive if they're asymptomatic and they've been tested, or 72 hours after the last fever without fever-reducing medication. So it's pretty standard now. I mean, we changed it a little bit so that if people are asymptomatic, so we're doing a lot of kind of mass testing, and Dr. Gounder will talk about that. If we've done mass testing and people do test positive, what we found is that sometimes there's a large number of people that are testing positive, and we don't want you to exclude everybody and cause a huge worker shortage. So one option would be to allow those workers to actually, the asymptomatic workers, to come back and just work with COVID positive patients alone. And so we kind of that's addressed as well in our mass testing guidance. But that's the only kind of significant change that we're talking about. The one thing I would say is kind of based on what I kind of mentioned before is that there's a test-based strategy, and then there is also a time-based strategy. I feel that both options are available per the CDC, but again, based on the fact that we do see people who actually have extended periods of positivity on their PCR, even without any symptoms, I kind of would recommend that people use the time-based strategy instead of the test-based strategy, just because the test-based strategy is a little problematic in a small percentage of patients that can, like I said, shed RNA for up to 48 days. So that's why we're saying kind of go to the time-based strategy. It's either one, they're interchangeable per the CDC. So I would kind of push that a little bit more than the test-based strategy.
And I don't think I added the time-based strategy, but I will say we've talked to a couple of administrators that highly recommend the 14 days rather than the 10 days. Two folks we spoke to took folks off the transmission-based precautions after 10 days and saw infections from those folks when they were put back into the quote unquote green zones of COVID naive folks. So I think your advice to follow the 14 days is probably pretty smart for the removal of transmission-based precautions. All right, so I asked Dr. Gounder to come on to talk about the testing. Obviously, on Monday, we were all notified that the state is going to now require everybody to have a plan to do testing in conjunction with their local health departments. Luckily, Los Angeles County has already started this process, so maybe Dr. Gounder could talk about where we are in the county for wide-scale testing.
Sure thing, and before I get into that, I'm just looking at the slides right here. The one thing I'll say about serologic testing is, for the most part, we don't really see any place for serologic testing in making a clinical diagnosis or making diagnostic decisions. So you can't necessarily say someone is safe to work because they're positive on a serologic test. You can't necessarily say someone was infected based on it. The only value that we see for serologic tests right now is in population-based studies that we do, where we try to estimate the prevalence of past exposure. And in that setting, we can make some adjustments for false positives and false negatives that allow us to make inferences at a population level that can't be extrapolated to the individual level. So the bottom line is we just discourage using serologic tests for any diagnostic testing at this time. In terms of the mass testing, we've made it a priority to try to test every single skilled nursing facility with an outbreak. This was prompted by evidence that started coming out from Seattle, where we saw that there was a large number of residents and staff who can have asymptomatic infections. Many of them eventually do go on to develop symptoms, but there's a small number that continue to remain asymptomatic with evidence of viral shedding. We believe that this potentially contributed to the rapid spread of outbreaks early in the course of the COVID-19 pandemic here in LA County. So we decided that it does make sense to do this type of comprehensive testing as the availability of testing has increased. So the testing capacity has increased in LA County. So at the moment, there are about 220 to 230 skilled nursing facilities that have had an outbreak since we started tracking this. We reached out to all of those facilities, and at this point, there's only about just under 100 facilities that we need to get through in terms of comprehensive testing. The rate limiting step for the testing has been facilities responding to our request for submitting the information we need to be able to pre-register them. So in order to do the testing in the facility, we need a list of all the staff and all the residents with the contact information, so the lab can generate the lab requisition form and the labels that are necessary for the testing. But as soon as facilities are able to provide us with this list, we're able to contact them and schedule a specific date. Our capacity right now is to do 15 facilities a day, and we're well below the capacity. We're testing closer to 5 to 10 a day. And again, the main bottleneck for us has been getting the lists from facilities. And we can understand that this is a challenge for facilities because this is just one of many competing demands on their time. But the sooner we can get that information, the sooner we can do this testing, the better we're able to consult with you in managing the outbreak to improve control and hopefully to resolve that outbreak sooner. So right now, like I said, that's the priority. But once that's done, I think we'll be in a better position to try to get ahead of this. And by getting ahead of it, I mean to try to detect these outbreaks early and to try to do this testing up front so we can contain an outbreak before it becomes more widespread like we've seen in some facilities. So soon, either today or tomorrow, we're going to be releasing a letter that touches on one part of that CDPH AFL that was just referred to, AFL on mitigation strategies. And there's one section on testing and cohorting and to work with the local health department on developing a plan for regular testing of residents and staff. At least locally for us, we're going to start by just providing guidance on regular testing of residents. We think to do staff at this point add the level of complexity that maybe facilities aren't ready for, but eventually we would like to do that. But the letter, what it's going to ask is for facilities to test weekly 10% of residents in their facility, or 10 residents if the facility is smaller than 100 residents. And to do that, we're going to encourage facilities to establish relationships with a commercial lab that's able to perform this testing. And then we will be following up with facilities on a weekly basis just to do an audit to figure out how many residents were tested and how many were positive. Theoretically, if you have any positive residents, they should be automatically reported to public health. So this is just a double check for us. The main intent for doing this type of active surveillance is if we're to identify even a single person with evidence of infection, then we would be able to deploy our public health teams to do this comprehensive testing of all residents and staff. And potentially, if we do identify an outbreak very early, so say, only a handful of residents are affected, then we could consider options like transferring these patients to a COVID designated facility for 14 days until they're no longer infectious. And by doing so, we could try to contain the spread of the outbreak within the facility. Likewise, if we're able to identify staff very early in the course of infection, then we could potentially isolate staff from having to work without precipitating a staffing shortage. So this is sort of what we envision moving forward, but I think I'm sure a lot of this will change once we actually start implementing it in terms of the challenges. But once we have testing capacity, the other part of the mass testing strategy that we'd like to implement as well is repeat testing on a weekly basis to assess for further transmission, and then to verify that facility is able to go at least 2 weeks without additional new diagnoses before we're able to close an outbreak. So that, again, depends a lot on the testing capacity in the community, and it really depends on facilities being able to establish a relationship with the lab that's able to provide timely turnaround of test results so they can make these decisions about cohorting and isolation. So I'll stop there to see if people have any questions about our plan or any feedback for how we can implement this moving forward.
Well, thank you, Dr. Gounder. I do have one question. In regards to the future with testing, when we look at, well, I just look at numbers and I go, we got 100 and something thousand people that work in our building and another 110 or 120,000 that live in the buildings. That's a massive amount to do on an ongoing basis. When we look at testing staff and knowing that this is the primary vector of how this gets into our building, is there any push to move to a more instant or a quicker return on tests? I know that the Sophia 2 antigen test that was approved for EUA on, I believe, a few days ago has kind of, well, it looks like, what it promises would be a panacea for testing all of our healthcare workforce, or at least being able to do surveillance testing of the healthcare workforce. Do you know if there's any movement to scale up that type of testing for the healthcare workers?
From our perspective, if the more rapid testing capability that's available, obviously the better it is for informing our public health response. But that's largely out of our control. It's up to facilities, I think, to establish relationships with labs that can provide that service, and it's up to labs to ramp up the capacity to do that. The Cepheid machine, I don't think is ever going to be a high throughput machine. I think even the largest machines only are able to do on the order of, I think 100 at a time. But the majority are not that big. I think they do maybe just a couple dozen. So I think, Cepheid can play a role in certain settings where having a timely diagnosis is important. In the hospital settings, I can think about, people who might need, surgery, urgent surgery, and you need to know, that this person doesn't have it before you intubate them. So in that setting, I could see that. But for the type of active surveillance that we're doing, I don't see that that type of a machine being the most feasible. But testing is changing quickly. I think we're going to continue to see more platforms out there that have higher throughput that can provide that faster turnaround time. until then, I agree with you. It is a limitation of our approach that we still have a turnaround time of potentially 2 to 3 days from the time we collect a specimen to the time we get a result. And during that time, you could have additional transmission that's occurring because people don't know about the infection status.
Yeah. Well, that just doubles down on you guys on the facilities, making sure that every healthcare worker is masked, because we're not going to discover that they're positive for maybe 24 to 72 hours at best. So we got to stay true to those infection control and infection prevention procedures. All right, I'm gonna move to the next slide here. All right, maybe there. Well, I went too far. All right, so now I'll just cover some brief announcements, and then we'll get right to the questions. So we've got a couple of ReadyNet training opportunities for those of you that have responded to numerous bed poll requests and a number of requests. Know that this is very important in our communication platform with the county. If you've not joined ReadyNet, or if you need a refresher on how to work within ReadyNet, we've got 2 sessions set up that you can register, and these are all free for you to do. All right, and so in regards to PPE, we've obviously you guys have all received supply shipments from the Medical Alert Center, and sometimes they've come in miscellaneous sizes and shapes and makes and models, and whatever the Medical Alert Center had, they sent out to folks. If you find that you have a ton of supply of one specific thing and it does not meet your need, a provider in Los Angeles County has started a Google form that each facility can go onto the form and put the sizes and make and models which they have extras of, and they can put requests in for what size and make and model they need. We're trying to marry the supply capacity. So if you guys are really hurting for supplies, but you got 5,000 small N95 masks and you need 1,000 mediums and 1,000 larges, that's the place where you want to go put that information. And we've had a number of providers already use that, and the provider that originally set up the Google document is going to do all of the logistical support in terms of moving the PPE around.
Jason, can I just say something,
Yeah.
please? So FEMA has a distribution going out. It should have been this week. I just wanted to let the people know that LA County EMS does not have anything to do with that. And then just to remind folks that we push out PPE as it comes in. So a resource request really just slows down operations here. As soon as we get it, we know skilled nursing facilities and hospitals are a priority. So we just push it out. I mean, if you go back to when we started, it's been learn as you go. We were trying to do it on a burn rate, and then we just did it on a tiered system where if you're over 149 patients, you get so much PPE. If you're 100 to 149, you get so much, and then under 100, so forth is how we did it. And then, so no resource request to us for PPE. We have nothing to do with the FEMA distribution. I think that's publicly available for them. And then I just wanted to go back to the staffing, because for us, that's one of the things we cannot meet for skilled nursing facilities is the staffing needs. So I just wanted to let them know that in addition to what you said, that we have contacted the staffing registries that do have CNAs and LVNs available. So it's just kind of perplexing that people are putting resource requests in for staff when we've contacted the registries. There's 3 registries that I sent out previously. And then also I wanted to make people aware that Hospital Association of Southern California has a job portal that normally the focused audience is the hospital people, but they opened up a tab for skilled nursing facilities. 37 of the nearly 400 facilities in LA County have posted on that site. We've also been working with LinkedIn that we were going to do a recruitment for the skilled nursing facilities, but it was very complicated because of all the different job specs and pay wages and so forth. But we're still working with them to get postings on LinkedIn for skilled nursing facilities. We expanded the EMT scope of practice so they can utilize the EMTs similar to CNAs. We've deployed strike teams from the National Guard, Health Corps, and the VA is coming, and I don't have the number of facilities that we've deployed to, but it's like
It's
probably 5%
Yeah.
at least.
Yeah. It's a lot.
And then the alternate care sites. So I just wanted to remind people that there's a lot of avenues to explore for staffing, and then definitely what you said is have an emergency staffing plan and credentialing plan in that. And then one last thing is I sent out a decedent poll this morning to all the skilled nursing facilities to see if they have storage of bodies, dead bodies, I guess, and are they having any issues with the morgue pickup? And that was based on a request from the coroner. So thank you.
Yeah, thank you very much, Lori. And I will also mention that we have talked to public health about the long-term kind of issue with obtaining staffing. And they're going to start a program where they're going to collect information from EDD on unemployed or laid off healthcare workers and try to match them up with facilities that have need. That is going to be fleshed out in the next few days. It will be a part of that mitigation plan as well. So, all right, guys.
Excellent.
So
thank you.
Yeah, and thank you, Lori, and thank you guys, Dr. Rubin, Dr. Gunner. Thank you very much for everything. Our next webinar will be July 8th, 2020. And after today, if you need your CE evaluation, you want to see Courtney Kesterson. Courtney, do we have any questions? We've got about 7 minutes to go through them. So if you have any questions, fire away.
Yes, okay, so we have a few. I will try and address the ones regarding testing while we still have the doctors online. So our first question, would you still need to isolate a patient 14 days from a hospital admission date if they tested positive over 14 days ago and now are testing negative?
So this is Dr. Rubin. Yeah, so I mean, they can, so these kind of unusual situations where a patient may have tested positive in your facility and then gets admitted later on are these kind of weird situations. So I mean, we do recommend that you try to be we're trying to be conservative with these patients because they may be shedding longer if they get sicker and they're in the hospital. So, you know, one option would be just to, you know, start the 14 days over on the day that they return to the hospital. Another option would be to do serial testing and have 2 negative tests at least 24 hours apart to try to confirm clearance. Like I said before, sometimes the clearance PCRs can be a little problematic because people can shed for long periods of time, but those are the 2 options. So you can either kind of extend the period. So for example, they get tested and they're asymptomatic on day 1, they go 7 days, they get admitted to a hospital because they start getting sicker. Then I would restart the clock from the time that they're in the hospital for 14 days, or, you know, you could potentially do testing at the end of that to try to get the patient out of there, with the understanding that sometimes that backfires and the patient may actually be stuck there longer. Those are the 2 options.
Okay, thank you. Next question. After 14 days have passed upon admission to a SNF for a positive patient, are the patients able to be placed back in general population without testing?
Yeah, so as long as the patient is clinically improving, it's gone 14 days after their hospital date, or 14 days after they've been tested positive for being, if they're asymptomatic. If they've gone 14 days and they're clinically improving, you do not need to retest them. They can go back to the general population after that.
Okay, thank you. Another question, what is the difference between PCR and NAA testing?
So not much. I mean, there are a couple of, so testing for the virus comes in a couple of different forms. So there is direct detection of the virus, and that can be done with a PCR or polymerase chain reaction. That can be done with nucleic acid amplification test, or NAT, which is just slightly different from PCR, but I won't go into it. And then there's also the antigen test that Jason mentioned before. Those are all kind of detection of the actual virus itself. And for the most part, we're kind of viewing those interchangeably at the moment. That's different from the serologic test, which is an antibody test, which is kind of an unrelated and answers a different question, which is not do people have active infection at this time. It really is much better at getting to whether people were exposed to the virus before and whether they have detectable antibodies for the virus. So I think you can kind of differentiate, direct viral detection tests from antibody tests, and that's the way you can kind of think about it. So that nucleic acid amplification test, the antigen test, the PCR are all direct detection of the virus test.
Okay, thank you. And I think I have one more question for the doctors, and then Jason, if you want to answer some Cal OSHA questions I see here, we can go ahead and do that. So next question, how long should psychiatric patients coming from acute settings be isolated for admission to long-term placements? Should their testing be mandatory prior to admission?
So all those patients, going to any kind of congregate setting are covered under those transfer rules. So I would just, go through the transfer rules, and those patients that are admitted not for medical reasons but for other reasons are all covered under those transfer rules. So, for example, if a patient is transferred to an acute psych facility for psychiatric issues and nothing related to symptoms of active infection, they could be transferred back without testing. But if a patient, develops fever or something like that, either in the facility, the acute care facility, or your facility before they're transferred, then they should be tested before they come back. So I would just follow the transfer rules. They should cover, medical transfers and psychiatric transfers and all those, hopefully all those variations.
Okay, thank you very much. Those are the main questions I see as far as testing and isolation for patients. I'm going to move now to a question I see about Cal OSHA. So Jason, do you want to go past 3 o'clock to answer the Cal OSHA questions, or what would you like to do? All right, Jason, are you still on the line?
Yes, the Cal OSHA thing may take longer than a few minutes, but sure, go ahead, fire away.
Okay, can you please address the difference in guidance regarding public health and OSHA regarding the N95 mask requirements?
Well, I'm not certain there's differences. So Cal OSHA, the version, our California version of OSHA has requirements for initial fit testing of the N95 masks. That initial fit testing requirement has not been waived. So if you have an outbreak in your facility, it's expected that you fit test the staff that are going to be working in the COVID positive section at a minimum. I would try to fit test everybody, even if you don't have an outbreak. Now is the time to get your staff fit tested. You can do now. Cal OSHA's allowance is that you could do fit testing on site, and you could do what's called qualitative fit testing, which is a much easier process than the quantitative fit testing that's required. But you have to do it in conjunction with a model respiratory protection program. We have a template for a model respiratory protection program that is on our website. It's free of charge. You don't have to develop yourself. If you already have one, that's great. You can take ours and borrow from it, or cut it up and make it your own. You certainly can. But a model respiratory protection program is not just the initial fit testing. It's initial fit testing, it's training, it's medical clearance, it's a lot of these things. We know some of those will be impossible to accomplish right now. And Cal OSHA, through our conversations with them, has said that they're not doing enforcement during this time to oversee that compliance, but their expectation is that you are moving to a full model respiratory protection program if you're going to have COVID in your building. If your plan, now this is what Cal OSHA says, if your plan is to transfer, forgive me, there's a plane flying overhead. If your plan is to transfer out all COVID positive residents, then you would not be, then you would be what's called a referring employer, and you wouldn't have to have the model respiratory protection program. But CDPH says, and Los Angeles Department of Public Health say, essentially, if there's no clinical concern, you can't move these folks, or you're not allowed to move these folks. So how do we connect the two? The only method that we know of for you to be able to do that is to immediately start the initial fit testing process. Go through that qualitative fit testing process with your staff now. And then the guidance from Cal OSHA says, okay, we'll assume everybody's already gone through the initial fit testing process. If those people don't have access to N95 masks, per Cal OSHA guidance, they can use surgical masks in lieu of the N95 mask. And I believe that's called for in the crisis or contingency strategies on the CDC website for the extended use of PPE. So it all kind of circles back to that same thing. Cal OSHA says we're not going to enforce right now if you've not done it up to this point, but start doing it if you haven't already. There are contractors or vendors you could use to do it. You could buy the fit test kits and have somebody trained to do it on site. I know a number of providers that are doing that. Now they're doing their own qualitative fit testing on site with a qualified person. I'm sorry, guys, I live next to an airport and they fly overhead all day long. So if you have specific questions about Cal OSHA, I know it's a really long, drawn out process. Don't hesitate to contact me. I want to be cognizant of folks' times and cut the webinar off now. If you have questions, please email Courtney or myself, ckesterson@caf.org or jbelden@caf.org, and we'll be happy to help you out with whatever your questions are. So hopefully you guys have taken a lot from this webinar. It will be recorded and it will be available for free on the CAF YouTube page. So you can reference this and go back to it as needed. So thank you very much. And thank you panelists for joining us. We appreciate your help, and good luck to everybody out there in Los Angeles.